Morning everyone, thank you all for coming. My name is Audrey Bautista and I'm going to be doing a presentation on evidence-based practice and recent studies that have been done that have shown improvement in the area of venous thromboembolism and its effects during the hospital admission. So this is a capstone project for my school, and I looked at 2 different studies and was able to compare them and look at data that different hospitals around the U.S. are doing and things that this unit could be doing differently. So what is VTE? Venous thromboembolism, or VTE, is it's kind of an umbrella term that's used to describe 2 different conditions. It's DVT and pulmonary embolus. It's basically when a clot forms in a vein and is broken off out of the vasculature into either the lungs, which is called a pulmonary embolism, and then oftentimes can also cause a stroke or an MI. VTE is an umbrella term for basically just when the clot is formed within the vessel. So risk factors for that, for DVT, include things that we constantly educate our patients about, like obesity, being overweight, smoking, and recently we've discovered that female hormone replacement is actually a huge cause of venous thrombus formation due to the extra hormones in the body. Long periods of not moving, so that is a huge issue, especially with ICU patients who are kind of sedentary in bed, and we have that happen a lot around here. Traveling at high altitudes, like in a plane, post-surgical, we do have surgery patients on the unit, and that is oftentimes an issue. We have to administer things like heparin, sub-Q, and do things like early ambulation after the surgery. Diabetes, any kind of vascular disease or anything that's going to cause the body to sort of remain stagnant. And then injury, other medications can help to cause this, and poor diet. So this is just a risk factor assessment. It goes from low, moderate to high. Low would be your post-operative period, like minor surgery, things like an angiocath. We can usually get those people up the next day. The moderate would be a major surgery, like a cranie or something like that, or open heart surgery, something that's a large surgery for the patient. This would require the patient to be bedridden for a longer period of time. And then the high is the post-operative following a major acute illness or a recent history or current DVT that's in the body. So the early ambulation is recommended for all of the above as long as the patient can tolerate it. I did put it in the low risk level assessment because those are the people that are going to be more likely to be able to ambulate at an early period of time. I spoke earlier about subcutaneous heparin. That is oftentimes weight-based. After people have below-the-knee amputations, they're often given enoxaparin or Lovenox. And, of course, PT-OT consult. You want to make sure you're utilizing your physical therapist and your occupational therapist because they can be really beneficial in helping us get our patients up out of their beds and walking, putting on their SCDs or their TED hose stockings, whatever's most appropriate for that patient. And then, of course, we use like antiplatelet drugs and higher thigh compression devices for the longer the patient will be bedridden. As long as there's no contraindication for medication administration, such as the enoxaparin, which is an anticoagulant, or heparin, which is also an anticoagulant, you can administer those usually every 8 to every 12 hours subcutaneously, and that helps to prevent the formation of DVT, but not rid any DVTs that would be in the body. So this is Virchow's triad. This is basically, it was named after a scientist, and he basically came up with kind of a tier system that overlaps one another. It involves stasis, injury, and thrombophilia, and where the patient falls within that spectrum. Stasis is going to be your immobility, things like CHF, congestive heart failure, that would affect your body's ability to move the blood around and get perfusion going, and kind of creates more of a stagnant blood environment, which puts the patient at higher risk for developing clot formation. There's also injury and like trauma and surgery, so the major and minor surgeries that we just discussed, and also when you have trauma to the site, bleeding occurs, clot formation comes out, you have your clotting cascade, and that will create sometimes venous thrombi, and those can break off and cause a PE. And then thrombophilia, things like what we discussed earlier with the oral contraceptives, cancer drugs, and then any hereditary abnormalities that the patient may have. So this is Virchow's triad in depth, a little diagram of it. You have the endothelial damage that we just discussed. This can also be caused by smoking and hypertension. And then surgery, things like, a lot of the ICU patients, especially on this floor, have PICC lines or central lines. That is an injury to the vein, which your body automatically wants to throw that clotting cascade and put a clot somewhere near the line. So we use things like heparin to lock the line, and then also a low-dose alteplase that helps to that's an actual, gets rid of a clot formation around the catheter. And then trauma, like we just discussed. There are also hereditary insufficiencies that you can discuss with your physician if that puts the patient at a higher risk for venous thromboembolism or thrombus formation. And then the acquired ones such as cancer, chemotherapy, and then as we previously discussed, immobility and polycythemia. So the pathophysiology behind this, most DVTs form in the calf veins in the lower half of the body, and that's why we have SCDs on the calves. We also have the ones that go on the thighs. And